Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Excellent article in the Washington Post on how ultra-processed foods are unhealthy for you, and they have a wonderful diagram on comparing how food can be prepared, and also how the difference between that and ultra-processed foods. And it's alarming to be able to actually look at the many processes that food may go through in order to be ultra-processed and turned from healthy to unhealthy. There's another interesting there's an article on the issue of what to do about sleep supplements, and probably the best sleep supplement is no sleep supplement. But there's an article on that, and then despair about the fact that a lot of people who have hepatitis C are not being treated, and then of course a great article on something that Darryl has mentioned before, and that is that the wearing of hearing aids reduces Alzheimer's by 50%, and recommending strongly that people who have hearing problems wear hearing aids, and that's something that actually Darryl has been talking about for quite a while. Yeah. So I guess we can get started on articles. Fortunately, we don't have as many as we had last week. So.
Oh boy, yeah. Okie dokie, here we go.
Yeah, this is a good example of false press. I mean, in a sense, this is accurate. Woman with transplant uterus gives birth to a boy, but that's not the issue. The act as though this is something new. Actually, they've been doing uterus transplants for at least 5 years now, and they've had about 20 something odd live births since then. And they talk about 5% of people are born without a uterus, and how that most people without uterus can have uterus transplant. Excuse me, which can be done very successfully. But this article makes it appear as this is the first one. Excuse me. This is the reason they say it's the first is because the others were experimental, and so this one is not so much experimental. So, but when you read articles, you sometimes you take it for granted when they say it's the first. It's really the first. In point of fact, this is not the first. It's one of 20 that have been successfully done in the last 5 years. Now, how often has any of you encountered a woman who's born without a uterus? Nobody would publicize that. So they say 1 in 500 women born without a uterus. And so there is actually, and they call this uterine factor infertility. And these are women who are born with ovaries. So they have the hormonal stuff, but they just don't have the uterus for the child to be born. And so, there's actually thousands of women in the world who can be helped by uterine transplant, and who would not otherwise. And then there are women who have perfectly healthy who don't want to have children, and so these people can give their uteruses, donate their uteruses, so they can be. This can be done in life and shortly after death. So, but so far there's been no mortalities and 83% success rate of the uterine transplants. Now, we had mentioned before that this is part of the process of the allotransplant, composite allotransplant with the face, the uterus, the penis, and other body parts that are hands and feet and so forth. So it's a relatively about 10-year-old, 20-year-old transplant process that called composite allotransplantation that allows for these kinds of transplants to occur, which require special permission. Any question about this?
I definitely have a question. So this is a live. This can be a live donor situation.
Yes. Yes.
And are there like statistics about the health of the uterine donor?
Yes, 100%. There's been no mortalities, and about 83% success rate for the women who've received the uteruses. So it's a safe procedure. Safe procedure.
Dr. Callender, my question is, you mentioned about women born without a uterus. Would transplants also work for women who have uterine cancer and need a transplant?
Well, as you know, the absolute contraindication for transplantation is cancer. So you would probably, if you had uterine cancer, it's not a good idea to do that. But if, let's say, somebody insisted on it, you'd probably have to wait for about 5 years after the cancer was removed before you would do it. But remember, active infection and cancer are the absolute contraindications to transplantation. Any other thoughts or questions about this procedure? Somebody asked me if it was done in men. Well, you got to remember, you have to have ovaries, and you have to have progesterone and estrogen. So it's not likely to be effective in men who have testosterone. So, of course, you might ask, well, what about these women who turn into men, and if they have ovaries, then they could do it. Now, but if they're men, they don't have ovaries, and so they haven't worked that out yet. So right now it's just done for women who do not have uteruses, who have ovaries. Any other questions about this? This is amazing how we have, and in this particular instance, it was from a deceased donor, which is interesting because this is done by deceased donors or living donors, just as most kidney transplants are. And the ideal donor is somebody who's actually had children, and the uterus has been demonstrated to be effective at carrying children. So,
Dr. Callender, at a certain age, women start having children in general. And so with those uteruses still be transplantable?
I don't understand your question. Could you clarify it a little bit?
Yeah, after a certain age,
You after 50, like?
yeah, like after 50, women stop having children.
Right,
So,
because they don't have the hormonal balance either.
right. So my question comes to, would those uteruses be effective for transplantation?
Probably so. I don't know anyone. Yeah, because the women we're talking about are younger and they have the hormones, the estrogen production that's necessary, and they've got the ovary. So it's possible, yeah, as long as there's no defect in the uterus. Yeah, I would think that's possible.
Yeah.
It's just that
So,
if you're older, then you have more comorbidities, and therefore the surgery would be a little more dangerous.
aside from hormones, I would think that the primary reason why women are unable to have children is because because they run out of eggs, and that's a different organ. That's the ovaries. That's not the uterus.
Right. Okay.
Tell me my jacket.
Well, it's amazing, when we talk about many of the things we've done that are progressive, but two areas which we've done nothing about is alcoholism and nicotine. We've done, for example, so people are still drinking themselves to death, and it seems that more women are consuming alcohol than men, and this is a concern because we legalize alcohol, legalize nicotine, and these drugs are killing us. Why women more than men? That's something I know the answer to, but that is an interesting finding that women's alcohol-related mortality increased significantly. Any thoughts? Why women drink more than men, or why they have mortality more than men after drinking alcohol?
Well, let's see. Just because of body fat composition, where women have higher percentage of body fat and higher percentage of body fat means less total blood compared to BMI in the system. And when you have lower blood content ratio, it can um, it can kick up your blood alcohol content with drinking fewer drinks. So that's the main reason. Long way around it, saying where men can take 2 drinks a day, women only one. And so that's a hard message. Most women don't realize that they really should be limited to no more than 1 drink a day and no more than 5 drinks of drink a week. And there's a lot of confusion about what is a drink. The main preference for women is wine, but they don't realize that 5 ounces of wine is a drink. Most of the time, you go to restaurants and bars, and they serve you about. They never serve you 5 ounces. It's generally about 8 to 10 ounces, and so half the time they're actually getting a double. They're getting 2 drinks in one glass. Um, and then there's a lot of confusion. They say, well, I'm just drinking champagne, and so that doesn't get me drunk as much as a Merlot or a Chardonnay. And that's actually not true because the carbonation makes the absorption of alcohol even quicker. And then the other thing that screws people up, they say I'm not an alcoholic because I don't drink every day. And that's not true. So there's a lot of myths around, alcohol that are creating an easy pathway to have alcohol dependency problems.
Yeah, the thing about it is that socially speaking, if you tell people you don't drink alcohol, they put you in a different category. And some people think it's socially irresponsible not to take a drink. And I think your discussion is an excellent one that puts things into the proper perspective. Any other comments on this?
A doctor told me one time that when he gets together with socially, he puts a stir and a lemon in his water, and it makes it look like he's drinking, and he's not.
That's pretty good.
Well, if we raise our children and ourselves to be resistant to peer pressure, we don't try to we don't try to fix it up to make like we do anything other than be what we are because we're proud to be what we are. If you're peer pressure resistant, that's the height of maturity. So, like, I don't care if anybody knows all I drink is water and I don't eat meat. Nobody's going to pressure me into doing anything.
I think that's a very interesting perspective that has guided me through my life. And we always say you want to be me, you don't want to be somebody else. So you can be strong, but this is what one of the women used as a reason that it's not acceptable to not drink with clients. Yeah, well, not acceptable to kill yourself. Yeah. Okay, let's go to the next one. It's very interesting. This is something that John Buchanan has been saying for a while, and now there's data to support it, that the number of people who actually have gone to the hospital and had coronavirus has increased. Now I got to remember that it's not what it was, but it certainly has gone up from what it had become. Whether you call it a summer mini spike or whatever, it's suggested that maybe you better go back to wearing masks when you're inside, as John Buchanan had suggested last week.
My life.
So how many of you still wear masks on when you go inside?
I wear mine in the grocery store.
Yeah, I do too. Yeah.
I
And
do.
yeah. Yeah, inside I think it's a good idea. In churches anymore, it's the rare situation where people wear masks, but still people wear masks in church. But I'd say 90% of people in church nowadays don't wear masks.
And look at this picture of Reagan National Airport. Those people are in close proximity.
Right. And that's the most dangerous place is airports.
I always
Yeah,
wear one in the airport.
airports. You got to wear them in airports because now airplane is okay because they have good ventilation, but in the airport, no way. That's yeah, and the train the same way. Yeah. The train station. Yeah. And still, some people still have not gotten the vaccination since last year, and remember the beauty of the vaccination is not that it prevents you from getting COVID, but it allows you not to die from COVID and not to require hospitalization. And so many of these people are just getting positive tests, but aren't having COVID. But what we're finding, though, is that the hospitalization of people with COVID is increasing. So we have to think twice about not wearing masks, especially when you're inside. Isn't that interesting? This is a figure that is disturbing. Only 17% has received the bivalent booster. Yeah, that's pretty low.
Dr. Kelly, I heard there's another booster coming up this
That's
year,
correct.
September,
Yeah.
October.
That's correct. Yeah, because the expectation is going to be an annual, just like the flu vaccine, annually the coronavirus vaccine. So those people who haven't gotten it by September, they should get the annual bivalent.
Yeah, I've had 4 so far. So September this year will be number 5 in injections.
For me, September will be the 6th for me.
Right, for me too. Yeah, it'll be 6 for me.
Yeah, I've had 3 of my friends come down with COVID after travel, and they were in airports and everything. Yeah, it's for me the biggest problem are those, like you mentioned, that did not get vaccinated. If you are vaccinated and you get COVID, it's been demonstrated, as far as I know, that the transmission rate from you being infected with COVID is a lot less than somebody who gets infected who is not vaccinated. So it's better for everybody if everybody gets vaccinated, of course. But
Yeah.
what I worry about are those folks, and it's a group of them. I'm going to put them together in a group that reject, being forced to get a vaccination. So they refuse to get vaccinated, and they get sick, and then go out in public. They don't wear a mask. They don't care about anybody else, and then somebody can die that way.
Well spoken. Let's go to the next one. This is something we have to keep in mind, though. This was an interesting article about bread intake, because 93% of the relative risk indicated no association of a lower risk of cancer. But then when they looked about it carefully, they found that there's a lower risk of colorectal cancer and total cancer mortality. One thing is they don't talk about whether it's brown bread or white bread, and it would be good to know what kind of bread they're talking about. But the effect, lower relative risk of cancer in the colorectal group is interesting. I'm not sure why that correlation with bread is there. And one of the things that it forces you to recognize is that because you have an association of findings does not mean that it's a cause and effect relationship. It suggests that. And if you have it above the 95% confidence level, then it suggests that it's significant. But it's not always that the statistical changes are cause and effect related. But this article suggests that bread does in some way protect you from cancer mortality. Can't say I believe it, but anyway, that's what the data says.
I had a question for Darryl about white bread. You have been telling us to avoid white bread. Is that the reason that they're talking about?
Yeah, white bread has less fiber. I think it said that. It's processed to make it white, and so most of the nutrients are removed in white bread. Um, and your deal, well, with most breads in America are made with wheat. They're, if you research wheat, it's problematic. Uh, but the thing I have most against bread is that it's high calories and high sodium. And in America, most of our health problems are coming from being overweight and hypertensive, especially with Black Americans. Um, you get one slice of bread has 100, on the average, 147 milligrams of sodium. You take two slices of bread for a sandwich, and so now you're up to close to 300 milligrams. You eat a couple sandwiches, and you're about half your daily consumption of sodium. So, yeah, bread is something that you can really eat sparingly and do okay. This article almost looks to me like it was written by the bread industry that says eat as much bread as you want and you'll get less colorectal cancer.
Well, I don't think that's the case, but I don't think it's written by somebody in the bread industry. But
I know, being
I do,
facetious.
yeah. But I do think that the difference between whole brown bread and white bread is very significant, and the same is true for milk chocolate and dark chocolate. Uh, Making it white makes it less healthy, and it's interesting uh, that they go to such extreme to make something white, almost as though they believe that white is right. But anyway, I'll leave that alone. I don't want to get Darryl in trouble. uh, this one, plant-based or animal-based diet, which is better? This is an interesting article that talks about it, and it's an interesting article because although we know that no offense, a plant-based diet is better, it still looks at both sides of the coin and tries to make a case that you can have a healthy diet even if you eat meat, if you eat the right meats, meaning fish as well as fish more than uh, other meats. But anyway, it's a good balanced article that talks about why actually plant-based diets are really uh, the best, but that meat-based diet uh, can be healthy as well if you just are particular about the meats you eat. I think that's the bottom line about what this article is saying is that plant-based diets are better for you, but if you like fish and some meat, lean meat, that you can have a healthy diet also. That when push comes to shove, that's what this article is all about. They also emphasize the fact that protein comes from plants as well as animals, and so to say that don't you don't eat uh, vegetables uh, plant diet because you can't get enough protein from uh, meat non-meats is inaccurate because you can get the same protein and the same amino acids just eating so that vegans and vegetarians both have enough protein regardless of whether they have meat or not. Yeah, you want to say something about the protein?
Oh yeah, get all the protein you need in plants, and as stringent as I am about a vegan diet, I don't have a problem eating meat when I go outside the country. Biggest problem I have with meat in America is it's the worst meat in the world. We um, we load it up with antibiotics, hormones, and
Yeah,
pesticides for their grain.
yeah,
We And we force animals to eat corn because it's cheaper than eating grass, because we do price supports for corn. It's not their natural diet, and it makes them sick. And that's why you have to keep them healthy with antibiotics to get them to market and so that you can sell them. The way that we grow meat in America is not done. The rest of the world, the chickens, the pork, the cows are grass fed. They're not corn fed, and so you don't have sick animals that you're eating in the rest of the world. They don't load them up generally with pesticides, hormones. We just do meat very badly over here.
Okay, I think you said it well, and
One other thing, Dr. Callender, I always remember something that you said about meat, and that was there was a blood product that you get from meat that you can't get from any other source.
yeah, and I think that uh, what they mean by that is that protein is easier to get from the animal than it is from the plants if you aren't careful in doing what you're doing. But on the other hand, the problem with the meat is if it's poisons, as Darryl has pointed out, then you have those problems. But it is a great source of protein, but it's just been processed so much by so many ways that it is abused here in the United States, as Darryl had said. But of course, we still have our octogenarians and centenarians who eat meat. But what does that say? Does that say that they have such profound protection from that in spite of eating meat they survive, or is it because of eating the meat? But we know that the healthiest diet is plant-based diet.
So, Dr. Callender, what's everybody's, if they're going to eat meat, what is their favorite meat? Is it T-bone steak or filet mignon?
Well, I kind of I remember the days when I used to eat a lot of steak. I don't do it anymore because I eat mostly fish now. But and I guess chicken. So poultry is for me. I don't know about others. I remember I used to try all the different kind of steaks to see what was the best one and all that stuff. But much ado about. I came to the conclusion much ado about nothing. Uh, you know, what others feel. Those of you who are meat eaters who like steak and that. And
I
any comments?
I used to like steaks, but yeah, I pretty much don't eat beef. Uh, maybe once a year I might have a burger or something like that. But yeah, way back in the day, I used to like Delmonico steaks, especially,
Mm,
and filet mignon. Yeah,
mm.
I used to like the taste of it, but I think I told you I had a positive colorectal cancer test when I was 25, and they said stop the red meat, and I did. And I guess a year later, I didn't have blood in my stool anymore, so I decided to keep it up. Uh, so no beef, but I still like bacon, and sausage. Well, maybe once a week. That's about it. And
Yeah,
somebody told me that pork is red meat, so
Absolutely.
it doesn't look red, but I guess it is.
It is.
I got something to say about soul food. Soul food has a lot of meats in the soul food legacy, and but it's not it's not black folks' legacy. Soul food is Paula Dean's diet. Is what we adopted in slavery from what the white folks told us to cook. So, if we're looking about what's our historical diet, there's nothing uh, that's historical about soul food for black folks. That's just Southern white diet. If you want to look for like what historically is best for us, you got to look for an African diet, which doesn't go predominantly meat as an entree for every meal.
Any other comments before we move on? Okay. One of the things that we've talked about before is the value of many of the plants, including the peanut uh, sources, which have been very good. This is something we mentioned before, but this FDA approval of over-the-counter nasal spray for opioid overdoses is something to uh, publicize so that anybody can get it and have it ready. So come across somebody on the street who's passed out, you give them the spray, and it's likely to be helpful. And it's the first over-the-counter drug that they have and it's because we have so many people overdosing. Have any of you purchased any of this over-the-counter narcotic? I've thought about it, but I don't. It was a time I used to take the public transportation everywhere, but after the pandemic, I stopped taking public transportation. And this had cost $50 to $70. That's kind of a heavy price to pay, but it's good to have around. It's kind of like the defibrillator, which saves lives. The difference is you don't. Most people don't pay for a defibrillator. It's either present or it's absent in places. And of course, the defibrillator is something that saves lives. So does this. Anyway, any comments about it? Anybody who's actually purchased it? There was some doubt by some people who didn't believe that fentanyl responded to it, but it does. So, and of course, fentanyl is apparently the drug of choice these days. Whether people want it or not, it's there. So,
I heard that it was going to be available in the high schools, that the nurses in high schools are going to have them.
that's a good idea. Good idea.
Alrighty.
Well, the only problem with the is that the $70 is a kind of heavy price to pay for it. It'd be nice if it could be cheaper. This is an article I thought is very important. This article reminds me of John Robinson and the many debates we had about the fact that the target blood pressure changes almost every other year. It's 120 over 80 is. And remember years ago, it used to be 140 over 90. And there are many studies that have looked at it. And I've seen so many varieties of variations on a theme that you almost wonder. Because it used to be that if you're over 60, it could be 140 over 90. And now, more recently, we've gone to 120 over 80 originally. And what they have said is that 120/80 is ideal. However, trying to keep a target of 120/80 is associated with many adverse effects. And because of these adverse effects, many people have reverted to 130/80 as a new target. But it's not because 120/80 is not desirable. It's because trying to keep it at 120/80, you overdo it and put people in shock and cause other kinds of complications. And so for that reason, many people are more comfortable with 130/80. And not too many people go back up to the 140/90. But I think I had an uncle that talked about this, and I think I'll let you look at it too, because it seems to me, though, that even though they recommend today, recommend 140/90, 130/80 sounds more reasonable. The reason that it's going up is because people over 65 are more sensitive to the changes in blood pressure if you go below 120. And so for that reason, they think that you have more problems with trying to accomplish 120/80 than you do if you stick for 130/80. And even though today the AFP recommend 140/90. But as John Robinson has said, it seems like every other year we have a new target for blood pressure. So, any thoughts about this? This is a very interesting topic that is important for us because we have 2 to 4 times the incidence of hypertension than any other ethnic group. Latinos are comparable, and the Native Americans as well.
It's important also. I mean, we have 3 or 4 articles about it. I put them in this order because this article is from February. I think, yeah, February. Then there's 2 other articles about it. So let's see what these other ones say. This next one is from June.
Yes. And I think that's important for us because diabetes and hypertension are the 2 biggest problems we have as people of color. And so, the problem, though, is that as you mentioned, we talk about a blood pressure for one population over 65, and we talk about blood pressure for population under 65, and then so it gets confusing. So now remember, this is the European Renal Association and the International Society of Hypertension that is giving this message, whereas the other paper was from the retired people, AARP, which is an older group. Yeah. So,
Dr. Callender, question: does keeping your blood pressure down help you to prevent osteoporosis, or does osteoporosis mean that your blood pressure is getting out of control?
well, arteriosclerosis means that you have cholesterol deposits in your blood vessels, and so arteriosclerosis causes you to have hypertension. So the question, which comes first, chicken or the egg? And the answer would be that arteriosclerosis is what comes first and is partly responsible for the higher blood pressure. And when we talk about high blood pressure, here again, they talk about 120/80 being the normal, 130/80, 130/90 being pre-hypertension, and 140/90 being hypertension. And this then is associated with cardiovascular risks of, but your question is which comes first, the chicken or the egg? My thinking is that the arteriosclerosis is the villain, which produces the hypertension. And it's not the hypertension that produces the arteriosclerosis. So in this article talks about going for 120/80, but 120/39 is suitable for the vast majority of patients, meaning they go into the 140/90 again. And they talk about the different types of blood pressure treatments, the ACE inhibitors, the angiotensin receptor blockers, and calcium channel blockers, and the diuretics, and so forth. And all of them have a place. And the truth of the matter is the medication that works best for you is what is best for you. Now, true resistant hypertension is what it means is that under the garden variety treatments, your blood pressure is not controlled. And of course, that is critical because one thing about arteriosclerosis, once you start having hypertension, that beats up the blood vessel and makes the arteriosclerosis even worse. So persistent hypertension is a good way to get heart disease, stroke, or kidney disease. So it's critical because the hypertension is a silent killer, and you have no symptoms. It then becomes important for everyone to have a blood pressure measuring apparatus at home, and then they should take their blood pressure at home. Why? Because when you go to the doctor's office, they have a phenomenon called white coat hypertension, in which when you go to the doctor's office, they don't have you sit down for 10 minutes and rest before you take your blood pressure and do things that are necessary. So if you did it at home, where you're comfortable, that probably is the optimal blood pressure.
Dr. Callender, I used to get mad because I would get to my appointment, and then I had to sit there. So, well, why did I get here to my appointment on time, and I still had to sit here? And then later I found out what we just said about that white coat. I definitely had that white coat syndrome, where my blood pressure goes up just because I see the doctor. But now, I understand I'm gonna get there 15 minutes early before my appointment, so I can, have my appointment on time. So
Yeah.
I can be rested, and my blood pressure will be. So I've had to have it rechecked several times, especially recently for some reason. I don't know why, but anyway.
Well, you could see that here they're talking about 130/80 for most patients. Europeans a little higher.
Dr. Callender, another question I have is the guessing game part of controlling your blood pressure, because you check it at home, you check it in the doctor's office, and sometimes it has to be changed around. In other words, sometimes you have to change the name of the blood pressure, and then sometimes you have to change the amount in milligrams of each of these different types of blood pressure medicine. I've had mine changed around, metoprolol and other different ones, hydralazine, and different amounts and so forth, different times of the day. That's the guessing part of it. That's very difficult.
What are you guessing about? I'm not quite understanding what you're guessing about.
Well, you get your blood pressure checked. You order blood pressure medicine. You go to the doctor, and your blood pressure is not being controlled well. Then the doctor may prescribe a different type of blood pressure medicine, or the doctor may increase the amount that you're taking. So it's one of those things where you have to constantly check to see if you need your blood pressure medicine changed or you need it increased.
Well, it's just called monitoring, and it's not guessing. It's doing what is appropriate, because uh, there is a phenomenon in which you take your blood pressure so much that it causes you to get your blood pressure to go up because you have so much anxiety about it. But it's really called monitoring. It's just a matter of, and I think that the best way to monitor it is for you to take your blood pressure at home. You take your blood pressure at home, and you keep a record of it. And probably taking your blood pressure more than twice a day is not beneficial, uh, because I think at one point you have so much anxiety over what's going on with your blood pressure that increases your blood pressure. So I think it's not a guessing game. It's something that you and your doctor together should address. And I think taking your pressure twice a day and recording it is a way of doing it. That's the way I used to do it with my patients. I had them keep a record of it and then bring that record to me of what their pressures were at home. And then I also did the pressure at the office. But I think the communication of it between you and the doctor becomes critical. It becomes a real issue nowadays, because after you do that, sometimes you can't find your doctor. And so if you have a doctor that's not accessible to you in the management of hypertension, then you have a problem all over again. And so keeping a record of your blood pressures and then sharing that record with your doctor takes the guessing out of it, from my perspective. This article again in July uh, is talks about the conflict and the fact that we go back and forth just like a yo-yo. Still, it's still around whether you go to 120 over 80, 130, or 140. And I think the way that you address it best is when the doctor and the patient have dialogue, and they together decide what's the best way to keep your blood pressure under control. I would tell you that we do our screens, and the group of patients that has the highest blood pressures are the people who know they have high blood pressure and are taking blood pressure medicines, but they don't take their medicine. And so I think it's important. It's interesting how they talked about this with President Roosevelt. He died of stroke because his pressures kept climbing. They didn't do anything about it. I think that one of the best ways to handle this is to be sure that you have a blood pressure apparatus and you measure your blood pressures. And if they are out of control, you and your doctor talk about how you're going to keep your blood pressure controlled, and what is the target that he wants for you and you want for you.
Dr. Count, another question is, you got a person who's 80 years old or 85 years old. Should you try to keep that person's blood pressure down to 120 over 80?
No. My answer would be no. I would say that if you kept that person at 130 over 80, you'd be okay. Being aggressive, and that's why they changed so much, because there were so many problems associated with trying to get 120/80 in somebody who's over 65, and they often had adverse events as a consequence of trying so hard to keep them at 120/80. So that my stance is that I would be married more likely to 130/80 than I would be to 120/80. Any other questions or comments relative to this topic, which is very timely? Now, this is an interesting graphic, which I think is reasonable, because common sense is rare, but common sense is desirable all the time. Because you're brilliant doesn't mean you have to have a lot of common sense. But if you have a lot of common sense, then you are brilliant. That's one way of looking at it. Anyway, this is a good thing to look at and recognize that there's a statement that is made that perfection is the enemy of good. And in this kind is what they mean is that if you get so obsessed with getting to 120/80, no offense, you can kill yourself. So I'm for accepting 130/80 and not trying to go to 120/80 for people who are over 65, and particularly people over 80. Let's have some discussion about that. And you know, the number one issue actually is access to care, because if you have high blood pressure and you can't reach your doctor and communicate with your doctor, then you're gonna not have your blood pressure controlled, and not having your blood pressure controlled is unhealthy. Period. Any other dialogue about it? Because I think it's a topic that. Now, how many of you actually have a blood pressure apparatus at home that you use to monitor your blood pressure? Because I think the one thing is true is that everybody should have one, and you should know what your blood pressure is. Just like you need to know what your blood sugar is, your hemoglobin A1C is, you should know what your blood pressure is. You should know what your cholesterol is as well. And yeah, so. Untreated hypertension kills, causes heart disease, strokes, and kidney disease. Okay, if there are no more comments or questions, let's go to the next one. This is something that we've been talking about since Denver Hamlin had his cardiac arrest, and we know now that Shaquille O'Neal's son had a heart attack last year, and now LeBron James' son had a cardiac arrest as well. So we're finding that one of the commonest causes of death in basketball players is cardiac arrest. And so the question is, what do you do about it? Well, one thing you do is you CPR. Next thing you do is you have a defibrillator. And the other thing is, after you have the cardiac arrest and you recover, you find out what caused it in the first place. And if you find out what caused it in the first place, some people, for example, Shaquille O'Neal's son had to have open heart surgery. What LeBron's son will need, we don't know yet, because some people just have arrhythmias, which is as fatal as anything else. And so they need to have pacemakers or other things, or actually internal defibrillators. So Exactly what is necessary remains to be seen. But the one thing is clear is if you have one of these events, it's important to know what caused it. And if you determine what's caused it, then that needs to be fixed before you go back to doing what you did that caused the heart attack in the first place, that caused the heart to stop in the first place. Now, I think the AED is one of the greatest inventions, and having it available is important for gymnasiums and airports. Yeah, and also important to know how to use it.
I'd be interested to know how many of us have been trained on the AED. I have. Anybody else? It's pretty simple, but if you don't know how to do it, you could get confused.
Yeah, yeah. And I think knowing CPR and how to use the AED is part of why a lot of people are alive today. And the first responders have to be aware of it.
As a dive professional, scuba diving professional, I have to be trained every 2 years on CPR, including the AED. So
That's good. It's good.
yeah.
Any other comments? Because I think this is something, one of the things that is counterproductive is if you have the AED all locked up and you can't get to it. So you got to have it to be accessible because you never know when somebody's going to drop dead. Who was the first one to do the internal defibrillator? Do you know? Levi Watkins at Johns Hopkins, a black surgeon, was the first one to put in the internal defibrillator. For people who have a ventricular, all kinds of fibrillation, and if they don't have it, they drop dead because there are arrhythmias that occur, and that's the commonest cause of people dying is arrhythmias.
So how does that work, Dr. Callender? Do you notice that you have the arrhythmia, then you press a button or something and it starts up?
No, it does it automatically.
Ooh.
It monitors, and when your heart is irregular, it shocks you.
Whoa. So what do you do if you need a battery change?
Oh, they actually change the batteries. Yeah, as a matter of fact, the science is that they trace that, and you have to have that change, just like the pacemaker. You have to have that change periodically, and they will check you and check the battery to see because that requires minor surgery. Some people would argue that there's no such thing as minor surgery. There's minor surgeons, but not minor surgery because all surgery is major. But anyway.
Dr. Callender, one question. They said that the battery on my pacemaker, the battery has to change like, 10 years, 10 to 15 years. But the other question I had for John, doing deep diving and getting under all that water pressure, could that cause tightness in your chest area?
Well, tightness in the chest is a symptom of a coronary artery disease. And if you had tightness in the chest, that would suggest that your coronary arteries are bad. So, many things can cause you to have coronary artery, cause you to get tightness in the chest. But most of them are the fact that you already have coronary artery disease. So if you have coronary artery disease and you go down underwater, yes, that could precipitate chest pain, yeah, or tightness of the chest.
Yeah, the
pain.
heart attack underwater, yeah.
Yeah.
Yeah, you have to go through if you have any conditions like that, you have to be cleared by your doctor.
One of the things clear is that ventricular fibrillation is lethal. And so if you don't have defibrillator, you die. So it's not optional. And so if you have irregularities like that, then that's why they put in the internal defibrillator, so that when your heart misbehaves like that, it shocks it back to normal.
Yeah, have you seen the commercials with Kareem Abdul-Jabbar talking about he's got AFib?
Yeah, AFib is different from VFib because VFib is fatal. AFib gives you a lot of complications, including blood clots and so forth and so on. But in itself, it generally is not lethal. So the difference between auricular fibrillation and ventricular fibrillation is night and day. But yes, I have seen that commercial.
Righty.
Okay, I guess we can go to the next one. We had a little discussion about this last time. Sorry, Carol isn't here, but
Carol is here, she's in the background.
oh, but oropharyngeal cancer or head and neck cancer is more likely to be caused by smoking and alcohol consumption. Yes, sexual behavior is a risk factor, and having STDs, sexually transmitted diseases, is more common. But I think this is to show that squamous cell cancer is associated with HPV, which can be associated with high-risk behavior, meaning cunnilingus and those kinds of things. And does anybody not know what cunnilingus is? Because I use that term and I realize that everybody's not equally understanding of some of the terms we use. Anybody not know what cunnilingus is? But anyway, just in case, cunnilingus is where you have oral sex in which the tongue of the male or female engages itself with the clitoris, in the vaginal clitoris, and this is then what leads to orgasms. And so the association of the tongue and the oral cavity with the vagina and the vaginal secretions is what allows the HPV. Now, of course, let's face facts. The HPV in the first place comes from the man to the woman. But after that, the woman has it and she can give it to the man and vice versa. So, but the point is that HPV is the common denominator that is responsible for cervical cancer and for oropharyngeal cancer. And that's why the early on you get the vaccine, the better off you are, and that they recommend it up until the age of 45. Can engage in oral sex increase your risk of cancer? And this answers it, but it still is not as commonly causing of it as smoking and alcohol, and so. But it is a risk factor. So and so we're having more publications that are identifying the oral sex, although they don't really spell it out like I just did. and I'm not sure that they want us to do that, but I think that may be necessary to help people understand what you're talking about, because they may read this and still not understand. And when you're growing up, it was not manly to admit that you engaged in cunnilingus, because you're a man, and it's your penis that's supposed to be causing the orgasm. But in some circumstances, it's the clitoral stimulation, and that's why, for example, in Africa and some places, and for the female, they take out the clitoris so that the woman doesn't enjoy sex so much. And so these are the terms that need to be used so that people understand what you're talking about, and that isn't often the case. Any comments about it? Although I've been kind of graphic in explaining it, maybe that more of that becomes necessary. Anybody have any problem with the way I explained it, or still does not understand it?
Dr. Callender, in the case of the Africans and other places where they remove the clitoris, what is the name of that operation?
Clitorectomy.
That's what I thought.
Now, of course, more recently, they have actually gotten a 2-round HPV vaccine, but it's important that men get it because they give it to women, and then women get it because they get it from men. But understanding how important this is important, because we have so many females dying of cervical cancer because of the HPV virus. And one of my friends, his wife died at the age of 30 from cervical cancer. So these are things that are important to recognize. What does this mean to you? It means that you, that your children should get the HPV vaccine in school. Now, I think we've done this before, but 8 habits that are good to increase your lifespan are worth repeating. Physically active, free from opioid addiction, no smoking. Now, the hardest of all is managing stress. If you're Black, managing stress becomes harder. Having a good diet, if you're an American, having a good diet becomes harder to do. You have to work at it. Binge drinking is something that is not something that is common among us, but occurs nonetheless. Having good sleep hygiene is easier to talk about than to actually do, because having 8 hours of sleep a night, no less than 6 hours of sleep a night, is more talked about than is actually practiced. And then finally, having positive social relationships is as important as any of the other 8 reasons. Any comments about this? Kind of simple. The only because very broad. They don't tell you how physically active you should be. 2 and 3 are straightforward. How do you manage stress? That's something. Do you use meditation? How do you manage it? You can't change from black to white, so you have to recognize that you're going to have this pigment and be able to manage stress, whether it's your relationship with God and Christ, or your God, or whatever. And a good diet we talked about. So now, habits. See, that's what makes life difficult, is whether you addicted to alcohol, addicted to sex, addicted to opioid, or whatever. Because these addicted to sugar, addicted to salt. These are things that we talk more about alcohol and nicotine than we do about salt and sugar, but they may be in the same category. And some would take away the may and just say that they're in the same category. Any other comments on this, which is maybe the reason why many of us have gotten to be able to be 50 and 60.
So, Dr. Callender, you said earlier about, this article talks about having good sleep hygiene, 6 to 8 hours. So then those people who are having trouble getting those 6 to 8 hours, you said earlier, no sleep medicine is better.
Yeah, and of course the article that we talked about earlier, or maybe we didn't talk about it, but there's an article that talks about this. It was the Washington Post section. They have an excellent article in this Tuesday session on sleep supplements. Talks about melatonin and all of those. And if you have to do those, it's okay, but it's not desirable. But there are sleep experts who actually, if you are really addicted to sleep medicine, there are sleep experts who can help you get off of those supplements. But supplements may be helpful if you need to get 6 to 8 hours. But if you have to use supplements, they should be short term and not long term.
Dr. Callender, I use a CPAP machine every time I sleep, even when I take a nap. Have there been any studies about any negative effects
No.
of CPAP?
Only positives. Only positive to say that they help you with hypertension and heart disease, and they keep you healthy. But I've not read any article that indicates that there are negative aspects of. There may be socially negative aspects, but no physically terrible. And now the question is, you've seen those commercials about Inspire, and I've not seen any studies on Inspire to see whether it works or not. We know that the CPAP works, and there's no negative aspect of CPAP that I know of.
And my son has I forget the description of it, but it's extreme what do they call it? The interruptions is the sleep interruption.
Yeah.
And I have mild, but they recommended that I get it because some people that when I've had to share a room, they wake me up and say, you're snoring, right? So to avoid that, I had a sleep study and use the CPAP, and I don't snore anymore, which is good. But yeah, disruptive sleep apnea, so and the reason I got it because my spouse snored like a freight train, and I told her she needed to get it. She said, well, you snore. So I said, well, I'll go ahead and get it. So eventually she got hers. So it worked out.
Thank you for sharing. Thank you very much for sharing. Okay.
Dr. Callender, I know I've asked you this question before. I apologize for asking it again. But sleep, 6 to 8 hours of sleep. If you wake up in the middle of the night, let's say after 3 or 4 hours, and you stay up a half an hour or maybe even an hour, and you go back to sleep, and you get your second 4 hours, does that count as
Yes.
as 8 hours of sleep?
Yes.
Mm. Okay.
Because your brain gets that the benefit of that total 8 hours.
Okay.
Now, this is an interesting article about how, and the way it's here, you wouldn't realize that uh, the one thing that they're talking about, they're talking about the microbiome and how the bacteria in the intestinal tract play a major role in your health. And they talk about how the many things that you do interact, including diet, as well as exercise. They talk about how the microbiome, which is the term they use for the balance between the good and bad bacteria that are in your intestinal tract. And it identifies that those who have the butyrate did better because of the fiber, etc. And so that the one thing that helps you among the things, even with the microbiome, is the exercise. And so that when push comes to shove, uh, the diet you eat and the exercise you do, your exercise, those two together are what makes for good health. And they're suggesting that one of the ways that it manifests itself is in the balance between the good and bad bacteria in your intestinal tract. So that the diet you have and the exercise together are the ideal combination. And so the one thing that they're talking about is the fact that the diet and exercise, and that's something that we've talked ad nauseum in this group about the importance of both.
Dr. Callender, I've benefited greatly from yoga. The stretching really helps your digestive system work. I want to recommend that highly.
Well, I think the data makes it clear that yoga is great, and that it's for those who practice it, it is very wonderful. And most of the medical literature has now recognized yoga as well as other exercises as being vital for health. I put this in there just because this is a fact. Most medical students don't go to class. And does that mean that they're going to be lousy doctors? That remains to be seen. But this article suggests that as long as you have the material that is essential for practicing medicine, it really doesn't matter whether you went to class or not. I don't agree, frankly. But they take the position that whether you look at the lecture on tape or you go to class itself doesn't matter. I don't agree with them because what you can't ask questions if you don't attend the lecture. And the question that somebody asks may or may not be similar to what you need to hear. So I think that having a flipped classroom model is a good way of doing it. But the bottom line is you need to be able to interact with your professors, take the benefit of his or her experiences in order to be the best doctor you can be. This article doesn't agree with that. This article says, for the most part, that while they don't attend class, they theoretically look at the lecture at their own time. But that's a presumption, not a fact. And that in the final analysis, they take exams and they pass exams. So therefore, they should be good doctors. I don't agree. It remains to be seen. But this article takes the perspective that lectures aren't necessary. And so it says that whether they go to class or not, they can still be good doctors. That's what this article is all about. And they have a lot of data that seems to support. But the presumption is that the students actually look at the recorded lectures. And that is a presumption that I'm not sure that I accept.
I agree with you, Dr. Callender. There's a good parallel towards music instruction. There's a lot of people learning to play instruments with online videos. And, when you compare that to actual instruction from a live instructor where you can ask questions, it's just, everybody learns a little differently. But if you're not in a position where you can ask questions, that recorded instruction, I don't think it could possibly be as good as live instruction and being in a classroom.
That's interesting, the music parallel. I didn't realize that there was that change now that you can actually learn how to play an instrument without the human interaction.
I remember, Dr. Callender, that a while back I was tasked with teaching physics, and I didn't do well in college in physics. So I had to take a year of physics in over the summer. And it was at GW. And as an adult, as opposed to being a college age student, I approached it altogether differently. I sat in the front row. And my hand was up asking questions. And after the class, the youngins that were in the class, man, I'm sure glad you asked that question, because I had that same question, but I was afraid to ask it.
Right.
That's how I definitely benefited from being on that front row.
Yeah. And interesting. Very interesting to hear that. Okay. Is that you have any more? Yeah. Oh yeah. This is we're getting more and more of these kinds of cases where somebody goes in a freshwater lake or pond and they get an infection that kills them. This is a very rare phenomenon, but it's something that is happening far too frequently, although it's not common. But the water that we swim in, for the most part, except for the ocean, if you're in pools, they are treated. But in some of the natural places, they have bacteria that we aren't aware of. And by the time they get to the hospital or get treated, it's too late. And here's the case where somebody died from that. And it seems like about every 6 to 8 months, we have a case like this. And actually, if you get to the hospital in time, we have medications that will treat this disease, but you need to make the diagnosis first. And often by the time they come to the hospital, they're already too far gone.
Yeah, there was a video, Doc, about this that said a couple things. One, that the symptoms were similar to other illnesses, so they were missed sometimes. But the worst one for me is that once they got the diagnosis of this amoeba, it was 97% fatal. So, and they recommended, if you're swimming in a pool, in a pond, or a freshwater lake. Some people use nose plugs or actually ear plugs to prevent the amoeba from getting up to your brain.
Yeah, and maybe you might not want to swim in those places at all. You know, it's nothing like the loss of a child. That's two things that hurt the most: the loss of a child and loss of a parent. And so that really hurts. Okay, that's I had suggested to John Tatum and Buchanan that next week I would, since this is National Minority Donor Awareness Month, that I would make a short presentation on National Minority Donor Awareness Month, as well as showing 3 of the videos that we produced to recognize National Minority Donor Awareness Month. And so I'm going to work with Mr. Buchanan between now and next week to have that presentation for you. Okay, any other comments about today's? It's been very interesting. One of our smaller audiences, but interesting articles nonetheless.
Yeah, Joyce Springfield put in the chat that she had to go early.
Right.
Yeah.